Hello, everyone. Today, we'll explore the laboratory tools used to diagnose autoimmune diseases, step by step, with clinical reasoning and examples. Autoimmune diseases represent a broad spectrum of disorders in which the body's immune system targets its own cells and tissues. Because clinical presentations overlap widely, laboratory testing plays a crucial role in both screening and confirmation. Our first step is always baseline laboratory evaluation. A complete blood count may reveal anemia of chronic disease, autoimmune hemolytic anemia, leukopenia, or thrombocytopenia, as we often see in systemic lupus erythematosus. Next, ESR and CRP provide a measure of systemic inflammation. ESR rises slowly and remains elevated in chronic inflammation, while CRP responds rapidly to acute activity or infection. Then we look at renal and liver function tests to detect organ involvement, especially before starting immunosuppressive therapy. Urinalysis with microscopy helps identify proteinuria or casts suggesting lupus nephritis. For suspected muscle involvement, elevated creatine kinase and aldolase suggest myositis, although a normal value never fully excludes it. Finally, serum protein electrophoresis may reveal a polyclonal hypergammaglobulinemia, characteristic of chronic autoimmune activity. These baseline investigations give us a map of systemic inflammation and organ function, guiding which specific immunologic tests to order next. Section 2. Autoantibody screening and ANA interpretation. The cornerstone screening test for systemic autoimmune disease is the anti-nuclear antibody, or ANA. It is performed by indirect immunofluorescence on HEP2 cells, the gold standard technique. A positive ANA simply means that antibodies are binding to nuclear components, but it does not by itself diagnose a specific disease. Up to 10 to 15% of healthy adults may have a low titer ANA. What matters most are two details, the titer and the pattern. Higher titers, such as 1/320 or above, and certain patterns like homogeneous or speckled, make autoimmune disease more likely. So when should you order ANA? Order it only when there's clinical suspicion, such as photosensitive rash, arthralgia, Raynaud's, or serositis. If ANA is positive, we then proceed to disease-specific antibodies, like anti-dsDNA, anti-SM, or extractable nuclear antigens. If ANA is negative and suspicion remains high, consider other antibody families such as ANCA, rheumatoid factor, or anti-CCP, depending on symptoms. In short, ANA is a screen, not a verdict. Always interpret it in the context of the patient's clinical story. Section 3, disease-specific autoantibodies and their clinical value. After screening, our next step is disease-specific antibody testing. These tests define and classify autoimmune diseases, and in many cases correlate with prognosis or organ involvement. For systemic lupus erythematosus, anti-dsDNA antibodies indicate disease activity, particularly lupus nephritis. Anti-SM antibodies, though less common, are highly specific and confirm the diagnosis. Complement levels, C3 and C4, often fall during active disease and rise with treatment response. In rheumatoid arthritis, we use two tests, rheumatoid factor and anti-CCP antibodies. Anti-CCP is more specific and predicts erosive disease. For antiphospholipid syndrome, we need a triple test, lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1 antibodies, each confirmed after 12 weeks to establish persistence. For vasculitis, the ANCA profile is vital. PR3-ANCA, classically CA, points toward granulomatosis with polyangiitis, whereas MPO-ANCA, PANCA, supports microscopic polyangiitis or eosinophilic GPA. In autoimmune thyroid disease, anti-TPO and antithyroglobulin confirm Hashimoto's, while TSI indicates Graves' disease. In celiac disease, tissue transglutaminase IgA with total IgA level is the preferred screen. In autoimmune liver diseases, anti-mitochondrial antibodies confirm primary biliary cholangitis, and anti-smooth muscle or LKM1 antibodies suggest autoimmune hepatitis. For myositis, antibodies like anti-Jo1, My2, or SRP not only diagnose but also predict lung involvement or response to therapy. And finally, for renal autoimmunity, anti-GBM antibodies diagnose Goodpasture syndrome, while anti-PLA2R is key in membranous nephropathy. These disease-specific markers bring precision, transforming vague symptoms into defined diagnostic categories. Section 4, functional and complement tests and practical pitfalls. Functional and complement assays help us understand immune activity rather than just presence of antibodies. The direct Coombs test, or direct anaglobulin test, confirms autoimmune hemolysis when red cells are being destroyed by antibodies. Complement assays, C3, C4, and CH50, reveal immune complex consumption, especially in active lupus. In antiphospholipid testing, functional clotting assays like the dilute Russell Viper venom test are used to detect lupus anticoagulant, but they're sensitive to interference from heparin and direct oral anticoagulants, a common pitfall. Cryoglobulin testing requires the sample to be kept warm until processed, otherwise the proteins precipitate, leading to false negatives. Flow cytometry is also used to quantify lymphocyte subsets and monitor B-cell depletion after rituximab therapy. In patients with neurologic or renal autoimmunity, cerebrospinal fluid or kidney biopsy may complement these tests when serology alone is inconclusive. Always remember, each test comes with limitations. The skill lies not in ordering more tests, but in ordering the right ones, interpreting them in context, and confirming persistence or activity where required. Section 5, putting it all together, the diagnostic algorithm and case examples. Now let's bring it all together in a logical sequence. Step 1, clinical evaluation. Identify which organs are involved. Step 2, baseline laboratory profile, CBC, ESR, CRP, renal and liver function, and urinalysis. Step 3, screening test. If systemic autoimmunity is suspected, start with ANA on HEP2 cells. Step 4, specific testing. Based on ANA pattern and clinical features, order targeted antibody panels, anti-dsDNA, ENA, RF, anti-CCP, ANCA, or APS profile. Step 5, functional assays and complement. Confirm immune activation and monitor response. Step 6, repeat or confirm. Certain antibodies, especially antiphospholipid ones, must be positive on 2 occasions 12 weeks apart. Let's take examples. A young woman with photosensitive rash and joint pain, ANA positive, anti-dsDNA high, complement low, classic SLE. A middle-aged man with sinusitis and renal failure, PR3 ANCA positive, granulomatosis with polyangiitis. A patient with repeated miscarriages, lupus anticoagulant and anticardiolipin positive on repeat testing, antiphospholipid syndrome. A nephrotic adult with positive anti-PLA2R, primary membranous nephropathy. Each case demonstrates how thoughtful sequencing of laboratory tests converts a confusing clinical picture into a clear, evidence-based diagnosis. In conclusion, autoimmune diagnosis is a journey, from inflammation detection to autoantibody identification and finally functional confirmation. Understanding why and when to order each test is the hallmark of good clinical reasoning. End note, optional closing voice line. This structured laboratory approach helps us detect autoimmunity early, avoid false positives, and tailor therapy accurately. Remember, the test supports the clinician's judgment, it never replaces it.